this is now going to be kind of the bread and butter of bringing it all together. That's how I think about our time this afternoon. We have a wonderful panel here who I'm going to pass over to each of them to introduce themselves to you. But the goal this afternoon is to go through cases that illustrate some pretty common pitfalls and pain points, not only in the treatment of Parkinson's, management, living with. It's things that if you run into Parkinson's clinically or socially, it's things you'll notice. And we're going to talk through from different perspectives on how we address them so that hopefully you can go home feeling better about them. So without further ado, I'm going to pass the invisible mic off, and you guys can introduce yourselves to everyone who's here as I sit on the giant podium and feel high.
Okay. Hi, I'm Clarisse Goas. I am a nurse practitioner, and I am also an adult child of someone who has Parkinson's. My dad has PD.
Hi everyone, I'm Renia. I'm the new social worker who joined Georgetown Neurology. I'm excited to be part of the team, the support person and patient advocate for our patients with Parkinson's and Lewy body disease.
And you know me, I've been here all week with all of you, and I'm excited to be part of this, to present alongside my friend and colleague and our social worker, and Clarisse is an honor, but it's also so incredible to be able to sit here alongside our patients and patients' care partner here from Georgetown. So I'll hand it over to Mr. and Mrs. Bovino. You go first.
I'm Kathy Bovino, and I am a person living with Parkinson's. My doctor is the wonderful Dr. Yaghi, who also diagnosed me, interestingly enough. I'll tell that later. I was diagnosed in January of 2018, and I also have the help of my wonderful husband.
So I'm Mike Bovino, and I'm lucky to be married to my beautiful wife, Kathy, who has Parkinson's. My father also had Parkinson's for 14 years, which I'll talk about as well. So I've had the perspective of caring for my father and now supporting my wife with Parkinson's.
Fantastic. So we're getting different perspectives from across the kind of the network and the touch points that people living with Parkinson's see every day. So before we dive in though, hi everybody, let's run through the stuff we have to do, which is these are the disclosures of the people on the stage. All potential conflicts have been mitigated, so we can scroll right through. And so we have cases, and I think, Clarisse, they're mainly yours, so you can lead us through them, and then we'll all chat about it. But the objective is to highlight the challenges to patients, care partners, and clinical teams in advanced PD, discuss the need for hospitalization with all the minefields that go into that, rehab, institutionalization, recognizing the pitfalls of therapies and polypharmacy, and of course, to all have a nice discussion on how we mitigate some of this risk. Fair enough. What a way to end it. Okay, I will pass it to you, Clarisse. If you could lead us through case number 1, which we are calling fluctuation anxiety.
Sure. So we've got a 65-year-old female patient with PD. She comes in for her office visit, of course. She's taking carbidopa, levodopa, 2 tabs every 2 hours. She's feeling extremely panicked in between each dosage, around 90 minutes or so. It's pretty severe. She stopped going out anywhere because she's really unsure of when this feeling of panic's going to hit. And then she also kind of feels just this general anxiety most of the time. So we've got her on sertraline 100 milligrams by mouth at bedtime. And the question is, what would you do next? But I was hoping that maybe before we started that, we could get a little insight on what does anxiety with PD feel like?
Not good. It's very all-encompassing, and you don't feel like there's a way out. You feel kind of trapped in your body and trapped in whatever situation you're in. You don't want to interact with anybody, even your care partner. I tend to want to stay in bed and just kind of literally curl up and do nothing. And often you don't even want to take your meds, which you know would help you. So it's kind of terrifying.
And I can definitely see why that would be. So this is most assuredly something that we deal with a lot in clinical practice. You know, and we really have to take a look at a couple of things, I would say. So one is, you know, is it an off fluctuation? So, you know, are you feeling this way because your medication is off? And then two, or is it just a generalized anxiety? Or I think what happens with our patients that we really struggle with when we're treating is that it's a little of column A and a little of column B. Which can be really tricky, especially when you're the person with it and we tell you, okay, we're going to change your meds, but it's going to take, you know, 6 weeks for it to kick in, which I think can be hard to hear. So in any case, I would love to punt a little bit and say, what would you do next?
I'm going to pose a question to Dr. Yaghi. Okay. Just a what do you think question. What do you think about that Q2-hour dosing and the anxiety coming on at 90 minutes?
You know, it's a really good question because we have different ways of looking at this. Thank you for asking because
you're welcome.
As a movement disorder specialist, Dr. Falconer and I, that's the first thing we think about, right? Say, oh my goodness.
That's where I went.
Let's go to the medicines. Let's go to the regimen. Let's see how frequently we're dosing medicine. What formulation of levodopa are we on? You know, anxiety can be generalized anxiety or it can fluctuate. And the case study here really talks about fluctuating anxiety. And when we hear the term fluctuating anxiety, what's the first thing that comes in our head? The fluctuating course of dopamine in our brains and bodies. And if wearing off could be the cause of the fluctuating anxiety, especially if someone's needing medicine every 2 hours to this degree, we were probably dealing with a fluctuator. Notice I didn't just say motor fluctuator, it could be a non-motor fluctuator. And that can manifest itself as panic and anxiety intermittently throughout the day as a function, not of a generalized anxiety disorder. As you see, this person is on sertraline already. That's another way of managing anxiety. There could be different layers to it. So the wearing off effect is where Dr. Falconer wanted me to kind of go. And I think that helps us because the management solution is different. We need to optimize dopaminergic therapy in a case like that.
The other thing I was going to mention, and I'll hand off to Kathy, is I'm glad you mentioned non-medicine treatment. So having a therapist is really important. And Kathy's very fortunate to have an outstanding therapist who works with you on anxiety and some of the challenges you face.
Right. It's hard to discern sometimes, you know, is this your medication wearing off? Because I can tell like a clock when my, can I say?
Yes.
My Rytari is wearing, I don't know if I can say the brand name. When my
we're all friends here. This is all.
Oh, okay. Don't tell anyone. When my Rytari is wearing off, I'm like a clock. I can tell exactly when that happens. And it's not always anxiety that's a result of that, but it can be. It's also a symptom of Parkinson's. It's also what am I looking for? Therapy
a condition
symptom, a condition, yeah.
Yes.
And so my therapist also works with me in conjunction with Dr. Yaghi and several other professionals to help mitigate that.
And Kathy also has, and you can talk about this, you also have depression that you were diagnosed in 1992. So there's an underlying depression that's there. And so oftentimes there's an interrelationship that's so critical that gets lost often in our medical system. Like there's, people kind of operate in silos. Mm-hmm. And so it's really important, you know, for the psychiatrist or the therapist to be working with the Parkinson's specialist, the movement disorders doctor, so they have that because I think you brought up really well. Sometimes you and Dr. Falconer may be looking at it through this lens.
Yes.
They're looking at it from a different lens, not through the Parkinson's lens. And if there was only some better overlap, I think we'd have so many more outcomes that are much more effective. Because Kathy's, again, her anxiety may be attributable more so to her condition of depression and anxiety. It might be manifested through Parkinson's because of the fluctuations in medication. But it's complicated, right? It's having that intersections of medical specialists who are working together as a team.
I think you bring up such a good point, both of you. You know, Dr. Falconer and I were saying, well, how do we create a regimen that maybe we're having a longer duration of benefit with an extended release formulation of levodopa? But it's really hard to find that cohesive team where, as you said, we're not in silos. And resource management is something, during an encounter, as Dr. Falconer, Clarisse, and I know, we may not have, number one, the know-how of resource management, how to send someone, which sort of therapist, which sort of center might we find those resources. And that's why having Renia on our team, and Dr. Falconer has another wonderful social worker, an outreach person that helps us with resource management is so important. Renia, how do we handle this from a social work standpoint?
Yeah, usually, initially when patients bring up about anxiety, so I ask them questions as to, okay, so what do you think the evidence is behind that thought that you have, and how do you feel about that? So more like aspects of cognitive behavior therapy, that how your thoughts, feelings could impact the way you're acting. Also, the other non-pharmacological method would be mindfulness, which sometimes I would share with patients videos, and there are a bunch of good, really influential videos that are free, available, that I share with the patients. It just teaches our patients how to practice mindfulness, maybe 5 minutes a day in the morning or whenever. Usually you feel like those anxiety symptoms are increasing, you could practice that, which is what it is just being aware of your body, being aware of the thoughts that you have, your bodily sensations, and just like observing it without judging it. And for the long term, I also try to explore finding therapists that are more specific and knowledgeable about Parkinson's disease. So I'm the support person for patients to be able to navigate all those challenges that they have.
Great.
Fantastic. To close it out, I'm going to throw a curveball and try to think about it a little differently. Isn't that the fun part? So who here's clinical, running people's medicine regimens? When and this speaks to Dr. Yaghi's point as well, when I see patients who are taking original carbidopa-levodopa every 2 hours, and they have intense periods of anxiety, much like this case, yes, I think about wearing off, but I also think about dysregulation. Because if you think about it, pharmacologically, in terms of the blood and what the brain is experiencing, those 2 tablets are probably hitting their peak at about 90 minutes. So what if, in this case, we aren't exactly dealing with wearing off? What if we're dealing with somebody who their body has gotten used to the feel-good effects of carbidopa-levodopa? It's something we don't talk about enough. They take their tablets, it hits a peak, and they get a little anxious because it's a lot, 2 tablets every 2 hours. And then as it starts to crash, what if they're experiencing a little bit of withdrawal anxiety? Because classic carbidopa-levodopa rapidly exits the brain. And this is the kind of patient that I think the end goal clinically would be the same, to try to smooth out and give predictable therapy. But I can tell you based on experience, and I want to know Dr. Yaghi's thought on this, and you too, Clarisse, sorry, you're like right outside of my corner vision, so so high up, apologies. This is a very, very hard patient to change medicine.
Yes.
Because if they're taking 2 tablets every 2 hours, which by the way is a crazy interval, in 2 tablets, think about it, then that's a person that even though they're having probably dysregulatory symptoms, they're anxious, they're probably panicked. I had a patient recently who told me that she wears off every 90 minutes and she feels like that she sweats, that there's a horse sitting on her chest, that she becomes diaphoretic. Again, withdrawal symptoms. They're extremely hard to change because even though it ain't working, any sort of changes tend to make those symptoms much more pronounced. What do you think?
I agree. I think that these patients are very hard to treat, and you want to so badly because they're so miserable. So in my experience, this is someone that I start using interesting approaches to, because for me at this point, I've probably maximized meds to some, or I've tried an extended release carbidopa-levodopa, opicapone,
And it fails miserably.
Yeah, it fails miserably. They can only do it for like 3 days because they're miserable. And then, and I've got them on, Effexor, you know what I mean. But I've got them on an SSNRI. I've tried a whole bunch of SSRIs. I've probably sent them to psychiatry to have them do the swab to figure out which medication is going to work best, or which one they're going to absorb the best. And I'm just kind of frustrated because they are so unhappy. So I'm going to consider, a surgical therapy in this patient. I will say I don't know. We don't have a lot of studies that particularly tell us if this particular symptom improves, and I feel like in practice, I don't know about you, but sometimes I see a good result, and sometimes I feel like I'm in the same spot. But I think that, that's something that I would consider. And if they're really panicked, I might give them a benzodiazepine. I'm going to weigh the pros and cons of falls and things like that. But if they are miserable every single day and they can't get out, and they've done CBT and we did all the things, those are the things I'm going to think about at that time.
I think, as you mentioned, Clarisse, looking just at this case at face value, I'm thinking how to critique it, right? The case is actually something we may run into a lot at big centers like ours. And the first thing that's striking is what Drew had mentioned, the pill burden and the number of times the patient needs to take their medicine and the fluctuations here at 90 minutes, every 90 minutes, like Dr. Falconer mentioned, as is the case with some of his patients that he sees, and he has to correct the regimen to treat them. But the first thing that strikes me is what's missing here? Rational polypharmacy. So if we're just relying on carbidopa, levodopa, this is potentially the older way of treating, right? I don't see rational polypharmacy employed here. And if we had started off perhaps with rational polypharmacy, with layering different medicines in combination, maybe those troughs wouldn't be as low and wouldn't be as frequent. And that number, in your lecture today, Dr. Falconer, you talked about what was the number one most burdensome in that questionnaire. What was the number one? It's the fluctuations. And so absolutely, if we rely on the older way of practicing with IR, carbidopa, levodopa, this is where things can be. And as Dr. Falconer said, when you see a patient in this state, already at this stage, on their medicine this frequently, it's hard to make changes. That transition is that much harder, I think, which speaks to the fact that you have to be proactive and intervene early.
Yeah, I use the word addiction with these patients. I tell them, and I've had 2 patients just like this in the past 6 months. One of them is a completely different person. She has DBS now. But even before we got to DBS, I laid it out for her. I said, you are addicted to this medicine. When you are wearing off, I even use the term you're jonesing for it, right? They have to acknowledge that that's the problem, because it won't be easy for a week or 2 to get off of this. Yeah. And I find that if you're honest about it, they get it. And then they just kind of suffer for 2 weeks, and magically they turn around, right? Then magically they come back and they're like, I am taking it every 5 hours, and I no longer have an elephant on my chest. And you're like, see? So we get them. Okay, good case, guys.
And just one last thing, I'm sorry.
Please.
This level of anxiety can end our patients up in the hospital.
Yeah.
And then they can get unneeded workups and evaluations of their heart. Go in, I can tell you case after case after case of people that might be in this situation. They end up in hospitals, ERs, they need cardiac evaluation, they're admitted for several days, and sometimes those chest symptoms can be misconstrued and misunderstood, and it's wearing off, and they can be severe. Those symptoms can be severe.
Yes, ma'am. Oh, sure. It's so hard.
Hard.
And they won't do well on Rytary. I've tried. The last 2 people I had, I did Rytary. I tried anything. It makes them worse because they don't feel the...
No, and then I feel like they get more psychosis.
Yeah,
because they extended releases.
Well, they get more psychosis because in these cases, usually, if you were to look at her physiology, she probably doesn't need 2 tablets per dose, right? She's taking 2 tablets per dose because that's the pop and the high that made her feel better at one point, and now she's fluctuating. So if we were to change her to Rytary, you would take this fluctuating curve and it would just be flat higher, and thus the psychosis and side effects, because that set point is probably already too high. But, oh, I would tell her, message me in 3 days with how you doing, I'll coach you through it. And I would go a half tablet at first and keep it at every 2 hours and just see. And then,
You mean 1.5?
1.5. I would lower it by a half, yeah. And just see. And then try to get her, I would challenge her to say, look, 2 hours is a lot. Try to get to 2.5 and just slowly try to widen that window. But it took me on my last patient probably 6 months. And she messaged me all the time.
Yeah.
Anybody comment?
The way that I would probably consider, I think we're talking about how to switch over to an extended release capsule form. I would go to what each dose is. So if they're on 2 tablets every 2 hours, if we get to the right dose of the extended release capsule, you should be able to, based on the per dose administration, see 1.2 hours more benefit, duration of benefit, beyond optimized carbidopa levodopa, right? And the way I think about it, and everyone is a little different, but it's anywhere between 2 to 3 times the individual dose administration of each time the person gets cinema. So if it's on 200, you go anywhere between 2 to 3 times that number in Rytari form. And then hopefully that's how you'll find it. But they may need an action plan, and it may take time, and you may want to change one single dose at a time, see how long the benefit lasts, and see exactly what happens as the concentration max, that pharmacokinetic curve, kicks in. Dr. Falconer was mentioning how long it takes for the Cinemet IR to kick in, right? But that's really why we kind of understand the pharmacokinetics of the extended release capsule and how we would then make that transition.
What do you make of the fact that patients who have anxiety or don't complain of anxiety when they wake up at a time when they was already drop and they basically have a valley.
Yeah.
Have anxiety in the morning when you wake up.
Did everybody hear the question he asked? If people have anxiety, especially the type we're talking about, why do they wake up without it? Because that's their lowest point of the day. Do you ever wake up with anxiety?
Yes.
Mm-hmm.
Yeah.
How does it feel?
That's a great question.
Do you feel that it's related to wearing off, or is it something different?
I had never thought about it until we talked on one of my visits, and it seems like it might be related to the medication, not having taken anything since 11 p.m., and then I wake up at 7, so there's that gap. It feels very short of breath. You don't want to get out of bed. You're very anxious about what's going to happen during the day.
How long does it take for that to go away after taking your medicine?
The medicine usually kicks in 30 to 45 minutes after I take it. So I take it at 7, so 7:30, 7:45.
Seems to me that a person who's fluctuating anxiety during the day may have it in the morning when they wake up, or maybe the fluctuating anxiety is related to the rate of the carbidopa, the levodopa leaving the system. I don't know.
Exactly. Yeah, that's what I think that tracks with what we're talking about with this case. Dopamine's a feel-good, happy hormone. Dopamine is the reason why people do cocaine. Sorry, it's true. Dopamine is why if you're at the casino and you hit the jackpot and the lights go off, it's why you take the money and put it back in, because of dopamine. It's the reason why my 6-year-old woke me up last night at 3 a.m. and I was fine with it, because she's like my little bubble of dopamine, right? Dopamine makes us feel good, and the immediacy of a surge of dopamine, especially with classic IR, can make people anxious. The immediacy of the withdrawal of artificial dopamine through the medicine leaving can make people incredibly anxious. So I think the overlying point is that usually, and this is what I tell patients, and I'm interested in the panel too, if you have anxiety, you have it with and without Parkinson's. We have to think about it as its own thing that Parkinson's ain't helping, right? And you can have different types of anxiety because of that. But to you guys at the end, do you feel like the anxiety you feel is different at different times of the, I mean, this is a rhetorical question, of course it is, right? There's no one anxiety, would you agree
No,
with that?
it's different at different times of the day. I don't have it all the time, like every day, all the time. I mean, it's intermittent, but sometimes it's more of a panicky feeling. Sometimes it's more of a fear type feeling. Sometimes it's more of a wanting to avoid things feeling.
You've been working like with your therapist about even some things that bring you joy, you get anxious about or inhibited about doing.
Right. Like I do a Dance for Parkinson's program, and I absolutely love it. When I'm there, I'm just like as happy as can be. It's one of my favorite activities. But sometimes I'll be at home and I'll say to Mike, I'm not going to go today. And he'll say, why? And I'll say, I'm kind of afraid to go, and I'll come up with some strange reason. And it's an avoidance kind of anxiety. So
I will say, I'll speak about my father who had Parkinson's, and again, he was diagnosed in 1990, passed away in 2004, so a lot of these treatments, as I've said with Dr. Yaghi, weren't available. He had an amazing neurologist named Dr. Jacob Sage. You guys may know that, you know the name? He was with Robert Wood Johnson Hospital in New Brunswick, and fantastic, published papers, tremendous, compassionate, reminds me of Dr. Yaghi a little bit.
Oh, thanks.
But it's a big compliment because Kathy knows how much I admire Dr. Sage. I was with my dad on that journey for 14 years. And Dr. Sage was very good about, you know, trying to tell my father it is all about connection and being in the community. And what did my father in, it's the old saying, pride cometh before the fall. He allowed his Parkinson's to dictate how he was going to live his life. And it wasn't the Parkinson's. It was the way he viewed himself and how he thought others viewed him as well. And so he retreated from being around people. And I'm just sharing this with all of you because it's critical, because that was his downfall. I can't emphasize this enough. That was his downfall. And Dr. Sage was so wonderful in terms of trying to say to Mr. Bovino, if you do this and do this and do this, it's, you know, nobody's making any judgments on you, you know? But my dad withdrew. And not so much anxiety, but it does have to do with sort of mental state of mind. And this was unrelated, but a couple of years after he stopped less and less interacting with people and got more and more withdrawn and more self-conscious and things, he developed Lewy body dementia, which was terrible for those of you who have dealt with it. And the last 3.5 years of his life were very difficult because of all the symptoms he experienced. I know, different from this. But prior to the Lewy body dementia, where he actually, you look at him today and you'd be like, I don't understand. You know, yes, you show signs of Parkinson's, but this would inhibit you from interacting with people and playing cards. He used to play playing poker and cards, and he was in a community, in a senior retirement community, where all these activities were there, and I used to try to coordinate and reach out to all of his neighbors, go over and see him, please interact with him, and he just withdrew. And if for any of you, if you have the opportunity to try to encourage your patients, like this case patient here, the 65-year-old, I feel for her because I feel like she stopped going out anywhere. I'm thinking, it's my dad. Somebody is going to reach out to her and help bring her back into the sense of community. Her life's not going to be good quality of life.
Well, let's keep rolling because we have more cases. We'll get to it. Yes, ma'am.
I was just going to ask you, when your wife doesn't want to go to dance,
Yep.
do you encourage her?
Yes.
very much so.
Yes.
great.
Persistently, proactively, strongly,
works.
enthusiastically.
He's got a small taser. He just zaps it. It gets right out.
But I also respect her choices too, right? So I think with Kathy, I think that's why I mentioned she, and chime in, I know she's had depression since 1992. That's a whole different journey to navigate. So we've gone through that journey together for a long time. And I think I'm cognizant of that, because that could also be, that was different with my dad. My dad didn't have depression. My Kathy does. And so there is a backdrop to that sometimes she'll have depressive episodes that have nothing to do with Parkinson's, but that's what's causing some of the anxiety.
Yeah, I agree. He's very sensitive to which thing it is that's driving my poor decision. And he encourages me in a really supportive way because he knows how important it is to me, and the social aspect, the exercise, just everything about it is fantastic. And once I get there, I'm happy as can be, so
You have high dopamine levels.
very much so.
Okay, let's keep rolling because we've got some more cases. I think I can summarize it by saying that anxiety is no fun in real life, but fantastic if you're playing Scrabble because it's worth 17 points. 17, yep, 17, that's a good word. Okay, so we kind of summarized this, and no, we talked about all this, and we talked about this. So see, that's the fun part. You don't have to look at slides, we can all just talk about it. Okay, since anxiety naturally led into dopamine dysregulation syndrome, this was not on purpose, but here it is. Can you tell us about this patient?
Sure. So we've got a young onset patient, so a 40-year-old male patient with carbidopa, levodopa, and enteral suspension, also known as duopa, presents to the office. He sent numerous MyChart messages stating that he feels he is off. We've had GI check his tube. They told us it's working well. There's no clogs. There's no problems with it. It's in the right spot. He tells me he's using his extra dose as often as possible. When he comes into the office, he's sweaty, he's severely dyskinetic, he's talking quickly. I do a quick UPDRS, it's a 5. He's telling me that he feels off right in front of me. He's even taking extra oral carbidopa, levodopa, still doesn't feel like he's on. He can't sleep. He's running the pump 24 hours or as long as he can until his cassette runs out. I note that his wife isn't here today, and I just, ask him, where is she? Is she on a trip? And he says, no, they're separated due to some disagreements lately. So then the question is, what do we do next?
And thankfully, we're going to spare the Bovino family from this one because this is not you, and you have a great doc. Not that this is a bad doc, but you know what I mean. I don't think Dr. Yaghi is going to put you in this position.
No, not at all.
Boy, this is a tough one. Who here, anybody seen a patient similar to this? Yeah, it's, oh my goodness. I actually want to take this one first from the social work perspective, only because, not just to throw a cannonball at you, because this is a patient who is beating down the physician's MyChart, and if they have any contact in the clinic, nursing or social work, they're beating your door down too. It's like, how would you approach this from, like, let's say you got 5 calls from this guy on a Thursday, and you pick up and he tells you this. How would you navigate that? The easy questions, right?
Yeah, I usually want to know, okay, first is the medical aspect of it. Have you talked to your doctor? Of course, seems like they've been trying to communicate via portal, but maybe we should do an earlier visit with your neurologist, or at least starting with your primary care physician to see whether there's any systemic illness that needs to be ruled out. If not, then maybe an appointment with neurologist would help to discuss that. And then once that discussed, then we could talk more about the dopamine dysregulation and the impact that has on their behavior and how to cope with it. And social work would come in that aspect that, okay, let's talk about some coping mechanism that we can work when you're experiencing these symptoms. So I know it sounds more like a generic response, but I just always want to make sure they have their medical aspect ruled out by a physician.
And what Renia is saying is so helpful for us. She's a conduit of communication, a conduit of outreach. And what she's doing when she says what she just said is that she's helping tease out, where it is that Clarisse, Dr. Falconer, and I can really help, and where it is that we need help from her and from others like her that can really focus on everything with resource management, education, coping mechanisms, therapy. Truly, I think this is a tough case, medically speaking, because we don't have a medicine specifically for dopamine dysregulation.
No.
I mean, so look at what we came up with the earlier cases. Maybe extended release, maybe cut back on the levodopa, but the trade-off there is more off time as well, which has carries its own psychiatric burden. So this is tough. This is absolutely a tough case.
And this is a case where he's going to make enemies too, because this is the patient that here in DC would have seen Dr. Yaghi, would have an appointment with me, would be in with Hopkins, would be in with the local community doc, And he'd be seeing all of them at the same time, just looking for a fix for something that truly is, I use the word addiction. This is a gentleman who's addicted to levodopa. And so with that, and I'll advance it because I think we kind of covered this one pretty well through our first pass.
Yeah, we did.
What would you think about putting him on Seroquel initially? Due to hypomanic quality?
And there's data to, or somewhat data to support second generation antipsychotic use. There is. There was a case report we found on aripiprazole or Abilify. I've seen success with low doses of Abilify, even if you have someone who, in this case, is probably like 80 pounds soaking wet, if that, right? A little low dose of olanzapine in the evening will help them gain weight and might help some of the punding and the perseverative behavior. There's also a Depakote, where there are case reports, correct? Yeah. And there are no studies on going to levodopa gel as being the solution. I think it's important not because it might not help, but this case also illustrates what we were talking about with the last case, which is that sometimes just trying to fix it as a Parkinson's problem doesn't work.
Right.
I think you mentioned that too, right?
Yeah, and I think it's hard to, because if someone's addicted to something and you tell them just don't take it, but we don't have that option here, so it just makes it tricky, and just making sure that we have that multidisciplinary approach to it and that we're all trying to come from the same side. And I think something else is when we're thinking about treatment mechanisms for us as clinicians is it's important to remember that our early male patients, we just have to be a little bit more cognizant of this and just from the data that we have so that we're not making it worse and just keeping that in the back of our mind when we're making medication decisions.
Yeah, I remember I forgot who it was at Georgetown, but when I was training there, it was sage advice, we'll just say Dr. Pecan, reminded me that there's a percentage of people across the board that have addictive personalities. That's why alcoholism, that's why gambling, that's why all of these things that we know are not good for us, but people keep doing it. There's a percentage of the population that are just prone to addictive behavior, and they can get Parkinson's too. And I remember thinking that was kind of a big moment to realize, holy moly, we're giving people very potent feel-good, happy hormone, and there are people who, when we do that, taps into something that might have already been a problem, right?
Does somebody who takes carbidopa who does not have Parkinson's disease, does the medicine make him happy?
Yes. Yeah, well, I'll give you data that supports that. There's a clinical study, 2015, published in the Green Journal, where the authors tried to determine how good are we at diagnosing Parkinson's on purely a medication response. They took people who were diagnosed and followed them until they naturally left this world. No one was hurried along, thank you very much. And then they tried to confirm or refute the diagnosis on pathology. And if you were diagnosed by a general neurologist, the general neurologist tended to be wrong about 50% of the time. And if you're diagnosed by a fellowship-trained movement doc, we were still wrong 15% of the time. And so if you're talking 1 to 1.5 million people in the US with Parkinson's, that's a lot of misdiagnosis. And it all goes down to the classic approach to diagnosis, which is you sort of look like a duck, you walk like a duck, here, take dopamine, you feel better, you're a duck, right? But there are a lot of people, we see them frequently on the clinical side, who are misdiagnosed. You don't have Parkinson's, but we can't get you off levodopa now. You feel better on it, and it's because we're giving you artificial feel-good happy hormone. Any other thoughts on that?
Just agree.
No, absolutely. I think we as Dr. Falconer said, we talk about dopamine as being our feel-good neurotransmitter. So there's absolutely a lot of data in multiple publications speaking about all of our dopaminergic therapies and the effect on the positive effect on mood, positive effect on anxiety. But as Dr. Falconer mentioned, in cases of patients who may be prone to substance abuse or dopamine dysregulation, it's a hard case to handle. I'm struck by the different reports that you saw on how to treat it, and I guess in general, valproic acid, sodium valproate, does look here if it's successful in 5 out of 5 cases. We do utilize that in patients with some, to stabilize mood as a mood stabilizer. Sometimes we might use another anti-epileptic medicine that also is like lamotrigine, which may have a positive effect on mood stabilization. So, You know, we use medicines, but again, this is tough. This is,
You have great
That's
questions,
great.
though.
that's wonderful.
No one wants to sit here and hear us talk. We want to.
That's what these workshops are for.
Yeah. I will say, I was struck actually on this screen. I didn't realize they took a picture of my front stoop every day as the Amazon truck needs to back into my driveway or the haul that they deliver every day. Anybody else unique to that?
There's a question.
Oh, she does it too. There we go. Yes, ma'am.
So on a practical note,
Okay.
what are you going to do with this patient? Because to me, it's a crisis situation, right? So you've got to lower the levodopa. You've got to set new limits on his pump,
Yeah.
and maybe even hospitalize so that you can get the psychosis under control.
Yeah. What actually happened
Yeah, please.
was we,
So this is a real case, not just inspired,
Yeah, all of
These are all real
inspired
cases.
by real events.
no,
Yeah.
these are
Okay.
real cases. So we worked with neuropsychiatry, and we did try Abilify, and we did reduce the pump, and we did lock him out of the pump, but then he learned how to lock himself into the pump. And then we started to try to regulate even more by writing the pump with only like a month's worth at a time, and then a week's worth at a time. And then he disappeared for a while. So he went elsewhere. And they, not knowing, increased the pump. And he had stopped his Abilify himself. So he got a divorce and wound up eventually back in our hospital, and was psychotic. He actually wasn't our hospital, it was an outside hospital. And they didn't know what the pump was, so they stopped it.
So is he psychotic with hallucinations and delusions?
He
or
was
is
then,
he-
by then, but he wasn't here. Here he was just potentially making a few poor life choices. And so, yeah, so then he finally made his way back to us, but by the time he got back to us, the pump had been taken out and he was on oral levodopa. And so he had a huge crash for about 6 months. But then we slowly have been putting him back on oral levodopa. And he is doing reasonably well. He's working closely with neuropsychiatry. He is in an assisted living facility where they give him his medications so he does not have access to them. And he's doing well, again, all things considered, but the disappearing act kept me up at night for a while.
I would just say, just generally speaking,
Yeah.
you know, a mood stabilizer is something that we can go to, you know, at least to try, you know, valproic acid, lamotrigine, you know, rather than a D2 blocker, you know, I think, you know, we have to kind of be able to parse out, you know, in this case is different, but just generally speaking, that might be a good option. But for the psychosis, of course, you know, that's a whole different world. We consider pimavanserin, and I know I think we have a case coming up about, you know, psychosis. So, but you're thinking rational polypharmacy now, and how to stabilize the mood, the psychosis, and still at the same time offer motor control. You know, and that's a tough balance to achieve.
Yeah.
We had a similar case, and he ended up with DBS.
Did it work?
Yes.
Good.
And he's on a
Yeah.
Lower dose.
minuscule dose of dopamine.
That's fantastic.
But he was terrified to even take that small dose.
Well, once they're off of this, they realize the problem. You can always see it when you're out. It's when you're in the middle that they can't see it. And it's always those are the patients, when you get them through it, that every visit, thank you. Like the lady who I did this last on, every time I see her, she's like, you know, I wouldn't be here if you wouldn't have yelled at me and told me that I was killing myself, right? Which I did. I had to sit her down and be like, and her husband there is enabling, and it was this real unfortunate, like he would just feed her pills whenever she complained. And I laid it out as an addiction, and that this was not going to end well in the next 6 months. And I scared the living crap out of her, and then she kind of backed away. But thankfully, this is a rare thing, right? And I can think of, over my career, 2 patients that disappeared on me too. And I had one of them who had so little insight into the problem because he could rationalize everything. He was super hypersexual, was spending lots of money on things he shouldn't. He even had people on the other side of the planet that he was supporting and, you know, really involved. The wife leaves him. He's spending all their money. And I finally got him to adjust his medicine, and then he disappeared, and I haven't heard of him since.
Yeah.
So it's tough. See, this wasn't going to be the easy one, but that's why we're all here together. Okay, let's keep rolling, everybody. Now, this next one is actually an interesting one because this is something we run into while we're on the vein of psychosis and psychiatric issues.
Sure. So this is a 78-year-old female patient that comes to my office after a hospitalization. She was previously on pramipexole, 4.5 milligrams XR per day. I think I inflated that a little bit, which was discontinued at an outside hospital due to hallucinations. When I saw her before, UPDRS was a 40 and now it's a 72. Husband states she doesn't want to do much of anything. He's unsure if she's even taking her medication, her carbidopa-levodopa at this point. When I chat with her, and she usually wants to tell me about all kinds of things, including her cats and knitting and a few other things, she says that she doesn't really see any point to living. She's not really taking her carbidopa-levodopa. She doesn't want to get out of bed. She doesn't want to shower. You know, she doesn't know if she should stay here. She doesn't have a plan. She's just kind of feels really blah, is what she tells me, which is unpleasant. So what shall we do next?
We've got a theme going. See, we're leading, the cases are all related to each other. Isn't that nice? So you can withdraw from pramipexole. You can withdraw from a dopamine agonist. It is a defined phenomenon, and it can result in hospitalizations. It can result in severe anxiety, depression, or abulia, the lack of wanting to do something. And it can result in psychosis, too. It can actually make patients, instead of treat hallucinations, can actually make them in some way psychotic. Thankfully, extremely rare, but we see patients like this, right? Dr. Yaghi, when was the last time you saw somebody withdraw from their dopamine agonist?
You know, it's a common, I would say it's not uncommon, like you mentioned. You know, if you look at this patient's UPDRS motor score, 40, now 72, and we're dealing with severe motor disease. And now we're also dealing with lack of tolerability to carbidopa-levodopa. That might be a reason why, if she's no longer taking her levodopa, maybe that's affecting her motor severity. And so, not to mention the suicidality, depression. And so we're really dealing with the overwhelming features here, aside from having severe motor disease or non-motor symptoms. And now, as Dr. Falconer mentioned, what can we do in a case like this? You have a patient that when they take their levodopa to help them move and help them walk, now their psychosis is worse. We're also dealing with suicidality. So it's multiple layers. Again, here's another theme. When you can't use a multitude of medicines, for example, if the dopamine agonists are off the table, especially due to intolerance, because of a predilection for hallucinations, it becomes a lot harder. There's, this hypersensitivity to dopaminergic treatments. These are the hard cases where you try and help someone move and you can't because they're intolerant to the treatments. And dopamine agonists are number one on our list, of course, but then levodopa is right there. So in cases like this, number one, we have to understand the psychiatric background and see how we can help. I'm missing some of the neuropsychiatric and neurocognitive analysis here, but I would have to figure out what the Montreal Cognitive Assessment, the severity of depression, because this person really needs rational polypharmacy again. And now dopamine agonists are off the table. Levodopa might be off the table because of hallucinations. So right off the bat, I'd love to get this person on pimavanserin. I'd love to get this person maybe on an SSRI. I'd love to get this person maybe on an acetylcholinesterase inhibitor. And maybe that's the therapeutic journey until we then address the motor symptoms. Because without that foundation, we might be stuck in the same boat of intolerant effects of levodopa.
Call me crazy. I'd put her back on a little low dose of pramipexole. In just my experience, call it an N of 5. But the patients who can't tolerate not having a dopamine agonist doesn't mean they can't have it at all. So the patients that tend to do better in this kind of situation is, not 4.5 milligrams of pramipexole or Nupro at 8 or name your medicine, but slip a little bit in. Maybe a 0.75 tablet at bedtime is enough to help with the withdrawal component and not induce overwhelming hallucinations that you can then also counter by adding pimavanserin or other psychiatric-based therapies. So kind of have your cake and eat it too. In fact, I'm thinking of a gentleman I saw recently that I got him off of his Nupro patch because he was hallucinating. And I was like the case before where I got 6 messages a day from him and his wife about how terrible he was doing and everything was miserable, the world was gray. I just put him on a 1 milligram patch and he feels great. Just a little bit of stimulation in there.
Dr. Falconer and Clarisse, I'm sorry, I just wanted to have the Bovinos chime in.
That's true.
Yeah.
Because I wonder, what it feels like to be a patient and care partner, knowing that all of these medicines have intolerant potential side effects. And have you ever experienced anything like this in terms of side effects to the medicines, and how's that been in your life?
Definitely. I was thinking that while you were all talking. I had hallucinations for, I think it was 2 weeks, 3 weeks.
It was a little bit longer than, yeah, it was a few weeks.
Where I was seeing, it happened all of a sudden. I was seeing swarms of bugs that look like ants crawling everywhere. They would be all over all of you, on the screens, everywhere, on the walls, which is incredibly distracting when you're trying to do anything, and it's kind of horrifying. Then I started seeing things that weren't there. I would see people, and like I was at the pool with a friend, and I looked over and I said, "Are there people like over there by Trader Joe's?" And she's looking at me like I'm nuts, and no, there's nobody over there. So then I was driving, and I would see like dogs running in front of the car or people stepping in front of the car. So I said, that's it, I'm not driving. I couldn't figure out which doctor to go to because I didn't have any idea where it was coming from. And I was doing some reading, which I do a lot of because I want to be well-versed on my condition, and saw that hallucinations could be a side effect of Parkinson's. So I called Dr. Yaghi's office, and he got me right in, which was fantastic. And we brainstormed for about an hour. I mean, he was so great and gave me all the time I needed and went over everything. Let's go through all your medicines. What could it be? And I shouldn't say the name of the medicine, should I?
Ask Clarisse on that one. Can she talk about medicines? Yes.
Because it's related to something.
That's okay.
So he said, well, what's changed? And so I'm racking my brain. I said, the only thing I can think of is since March, and it was like September, I lost like 60 pounds. So he's just sitting there thinking, and he said, how much GoCovery do you take? And I gave him the dose. It was, I can't remember what I take, but he said, you're taking too much for the weight you are now. You're taking a dose for what you were. So he said, go back to 1, cut it down, just take 1, and let's see what happens. Disappeared. It solved the entire problem. It was amazing. He's a magician.
Oh, thanks. Sorry, we set that one up. No, I'm kidding.
Yeah.
He's a
Where's my money?
pharmacologist.
And this went on for months. It wasn't weeks. This went on for months.
Yeah.
It was
Months.
horrible.
Where she really just couldn't, determine. And again, this was going back to my dad. In his later stages, he was having hallucinations, and he'd be in his home and he would see people. And thankfully, they weren't anything that made him scared. So, but they weren't there. He would be mystified, by like, why are you in my home? But it never disturbed him. But he'd have hallucinations. He'd see dogs. He'd see animals. There were no nightmares or anything like that. But again, those were definitely, going back a number of years ago, those were absolutely side effects from the medication he was on. In Kathy's case, I was concerned because new medications, like we should be having, yes, there's hallucinations are part of all this journey. But to Kathy's point, it was that medication adjustment, because that clearly had to do with the dosage load that she had with her weight dropped, you adjust the dosage, and then no more hallucinations. So thankfully, there was a very direct cause and effect, but I know with other patients, that's not the case. It's far more complicated.
Mm-hmm. Mm-hmm.
And you asked something, Dr. Yaghi, about is it polypharmacy? Do I have that right? I have to take a lot of meds because I have comorbid conditions? Okay, trying out these medical terms. But I have diabetes and sleep apnea and migraines, and I'm a medical mess. And so all these medicines have so many side effects, and when I look at them, I never know what side effect goes with which medicine or is coming from which medicine. So for example, fatigue is a side effect for almost everything I take. I also have sleep apnea. So I go to a sleep doctor who happens to be Dr. Yaghi's good friend. And we were sitting there for an hour trying to figure out, what do we do? I fall asleep when I'm driving, and that's so horribly dangerous. How do we mitigate that? And do I take another medicine? And so it really is complex when you're taking more than one medicine. Like I take 4 Parkinson's medications, and they work together really well. But then I have all the other ones. So yeah, it's a real challenge. It really is.
And so I feel like it's been a little gloom and doom. So this was actually a very positive. This was what I call my gateway patient. And so what I really got stuck on when I saw this patient is, how did someone just pull her off of 4.5 milligrams of extended release pramipexole and nobody told me? You know, nobody called me, nobody did anything. So this really frustrated me. And not that anybody did anything wrong, but the fact that I was unaware and that I couldn't help until so much later, right? I'm seeing her later where she's miserable and I didn't catch anything. So quick plug for AMDAP. But so I asked all of my nurse practitioner, our national group, I said, how do you guys manage these patients? What happens when your patients get in the hospital, et cetera, et cetera? So now, from this patient, we now are in the process of modeling after another institution who has been doing this for about 1.5 years, and it works really well, where at least inside of their hospitals, I get a notification anytime a patient with Parkinson's disease is admitted to the hospital. And then I'm able to send that care team a quick note saying, hey, I noticed that this patient was admitted to the hospital. They've got Parkinson's disease. If you need any help, please reach out and let us know. Also, here are just some, it's just a smart phrase of things that we don't recommend, or medications that we don't want you, don't want you to use, but we wouldn't recommend to use first line in the hospital. So that hopefully, at least within our own system, we can prevent some of these things from happening so that we can catch them a little bit earlier. So
Awesome.
It's been a good thing. It's a journey. We're still learning. But it does help a little bit to make sure, that we don't have dramatic med changes made. So.
Well, there we go. Well, let's keep cruising. Yes, sir. What you got?
Really quickly, would anything change if this had been labeled as apathy instead of depression? How would you treat if the condition comes up as apathy?
Apathy.
Yeah, that's a good question.
I think I would still I would use your method, and I would put on a little bit of pramipexole.
Just a little agonist.
To try to.
That brings up the question I'll ask you guys at the end. What about apathy? We all loop apathy, which is a general I summarize it as a not wanting to do things, right? It can be part of depression, can be part of anxiety, but then we have patients with Parkinson's who don't have either. And every clinic visit is the spouse saying, I really want him to get out, and he just doesn't want to do what he used to do. Do you feel like that? How does that play out in you guys' world?
I don't care.
Exactly. That was well put.
I'm sorry. You set me up.
That was a joke.
It was called an alley-oop.
You thought you were the only one doing the joke. You understand my wife here.
Yeah. Well, here's a little pramipexole. You'll feel a little better.
That would be a good question about your dad, probably.
And you can admit to having the taser now.
With my dad, it really wasn't apathy. It really did. It was the way he saw himself, right? That was really what decided. He made a conscious decision not to engage or go out and pull back, right? So that was definitely not apathy as much as I wanted him to. I could get him to do things. It was me, you know, because, you know, I'd come up and I was able to get him out to do things. But he's always very self-conscious about doing those things. So it wasn't apathy, but I do feel maybe people with apathy, if you have sort of a, you know, a strong support network is really important, right? I think that's really critical. I mean, you have to have people around you that care about you. I mean, it starts with the medical professionals, and I know, again, these case studies are really fascinating because, again, I feel like a lot of people slip through the cracks in the system. I don't know. I just feel like there's a lot of people that, I get it to a point, because a couple of my best friends are doctors, and they tell me about how hard it is to deal with patients. And they're good, because they'll go above and beyond to do that. I don't think every doctor does that. I'm not judging. I get it. I mean,
You're saying healthcare is not built to help people.
What's that?
You're saying healthcare is not built to help patients.
That's correct.
We heard it first today.
That is correct.
I'm saying that sarcastically because it absolutely is not built.
If we had a different panel, I'd go on. My wife knows about my feelings on these things that relates to taking care of people and how we need to do more. Insurance companies, don't get me started. I can do a whole 2-hour session on what my feelings are on health insurance, but I won't get you in trouble. But I'm very passionate about people helping each other. But to that point, community is important. So it starts with Dr. Yaghi, with Kathy, and myself, because through Dr. Yaghi, I benefit from that because he provides Kathy with some great knowledge and guidance that helps me. For my dad, it was Dr. Sage, who will always be at the top of the mountain because same thing. He was compassionate, caring, went the extra mile to doing that. But then you need to have that person in the home who's, you know, together with you, whether it be a spouse, whether it be a best friend, whether it be children, whether it be work colleagues. I mean, I think that's really critical. I mean, you live that life. What do you think?
I don't feel like apathy would describe anything. I feel I don't know the right word for it, and my medicine is wearing off, so the cognitive stuff starts going. My alarm will go off in just a second, yes. I can tell.
Doctor, I'll be happy you're going to be taking your medicine.
That's right. It's right here, Dr. Yaghi. It's that need for support, like Mike said. It's that need for community, and it's so critical. As a patient, I knew nobody with Parkinson's. Nobody. I knew Michael J. Fox, but he doesn't want to come to my house. So, but I didn't know anybody, and I had. Can I tell the story real fast?
Sure.
Yeah.
Okay.
I want to.
When I was diagnosed, it was a huge shock, and I didn't go in to Dr. Yaghi. I went in to my migraine doctor, and at the end of the visit, I had just this little twitch in my finger, and I said, "Oh, by the way, is this anything to do with my migraines?" And she said, she looked at it, and she said, "Do you mind if a movement specialist looks at it?" And I said, "I don't care. I don't even know what that is." So in comes the wonderful Dr. Yaghi. So total accident. And that's the Raitari song. So in comes Dr. Yaghi. He does his assessment, takes his time, and then lets me know, unfortunately, I think you have Parkinson's. And as you may remember, I burst into tears. And it wasn't because I had Parkinson's, it was because his dad had Parkinson's, and I knew he had taken care of his dad just so wonderfully. He was so fantastic, you know, and devoted, and it took up all his time. And his dad lived in New Jersey, and we live in DC, and he'd go back and forth every weekend, and if there were free days, he'd go then. And that's all I could think of was, oh my God, he's gonna have to take care of me. So I stopped crying finally. So fast forward, I'm still working, and fast forward to my retirement. I retired a year ago, and when it hit January of this year, that was my 6-year anniversary of being diagnosed, and it wouldn't have occurred to me except on that day, I just all of a sudden just completely had a complete meltdown. And I lost it, and I couldn't do anything. I didn't eat, I didn't drink anything. I just got into bed and cried for 2.5 days. So I found out I contacted my therapist, thank God, and she talked me through this and said, you're grieving over having Parkinson's and what you're losing. And she said, you never did it before because you were busy working. And I'm sorry, it'll probably make me cry. But you need to go through that because you did lose something and you've got to deal with that. So I had Mike, thank God, and 7 really good friends. I texted them, and I just did one text. They texted me back. They supported me in every way. They said they wouldn't bother me, but they were right there if I needed them. So anyway, do I need to stop?
No,
No, keep going.
Thank
We're just
you.
handing you this. Sorry.
I lost track of where I was. So after like 5 days, I started coming out of it, and I was doing a little reading, and I love Michael J. Fox, so I was reading some more about him, and I just kind of thought, you need support. You need to be around people with Parkinson's, because they'll get it. So I got on the computer, and I started Googling, and lo and behold, there were so many resources I had no idea. And like, just for example, Parkinson's Foundation, free stuff out the wazoo. I mean, they had dance for Parkinson's, boxing for Parkinson's, rock steady, but you have to pay for that, but still, it's there. Rock climbing, for God's sakes. Free speech classes.
Support groups.
What?
Support groups.
Support groups. And it was like, this giant menu of anything you wanted. So I crawled out of my hole and went to the Dance for Parkinson's, and that literally changed my life, because you walk in there, and everybody gets it. So encourage your patients or anybody you know, do that. It makes such a difference. I'm sorry.
It's okay.
You are good.
Mrs. Bovino, thank you for sharing on stage in front of everybody. I think don't say sorry, because this Congress, through the PMD Alliance and through Georgetown and with Dr. Falconer coming in, and you're utilizing some of the resources that his institution has to offer. It's a team approach even regionally, and then we work together, and there's so many patients that need us. There's so many patients that really don't know what you just mentioned.
You're right.
And for you, because you were able to go through the research process yourself, you were able to find things based on your know-how and your intellectual strengths. Yep. But there are so many people out there, imagine, that don't even have those resources, right, and that don't have big institutions that they can go see people. They don't live in a city where there are movement disorder specialists. There are places out there where there are no specialists like us, like Clarisse, like Dr. Falconer, and like everyone here that's trying to take care of all their patients in different parts of the country. There are dry zones where people have to drive for miles and miles and miles just to see a general neurologist, and dry zones where movement disorder specialists are there, you can't find one for tens of miles, hundreds of miles. So That's where Renia's role and Dr. Falconer's social worker's role becomes so important, because without those other things, we can manage everything we can from a clinical standpoint, but real support comes from everybody else. And not to mention the advanced practice providers that are so important. Dr. Falconer's APPs, they've come to this Congress and represented Dr. Falconer's group so well. And all the APPs here, they bring a completely different perspective. I could have never come up with these cases, Clarisse. These are really interesting and complex, nuanced cases. And I think they've brought about a lot of important discussion. So we have to thank both of you for telling your story and for teaching everyone here, not just all the clinical side, but also the emotional side to this condition and what it feels like to get diagnosed. I feel like it's easy for us to forget, it's very easy for us to forget that, the time we spend with people is incredibly impactful. They listen to every word we say sometimes. So every intonation, how we speak, how fast we speak, what we say, we have to be very measured in our approach, and we have to be kind, and we have to take care of our patients and educate. And hopefully this Congress helped us do that. And hearing your perspective, I think, allows for everyone else to remember we have to remain sensitive. And everyone's different in how they interpret their disease. And not everyone has a wonderful Mr. Bovino and
That's for sure.
Mrs. Bovino connection. So anyway, I just wanted to say that.
Yeah.
Thank you.
And the one thing I was going to mention that Kathy mentioned is so important, but if you're with fellow Parkinson's patients where you can share that journey together. I can't tell you how often Kathy's come home and talked about the value of being in a support group or being in dance, because you share similarities and differences, and it's a network. And the other thing, I know you wanted to mention this, but completely different in terms of having that support. It's people, but we also, Kathy's had great benefit out of somebody else in our life who gives you great therapy.
Oh, my cat.
Oh, yes.
But in all seriousness, they
Yeah.
talk about like
Oh,
therapy, animals, and again, you talk
Definitely.
about where these dry zones where people may not be around people.
Yeah.
Animals are powerful,
Oh.
and this cat, Henry, is very, very therapeutic. And we got lucky. He was a rescue cat who was sadly abused, and we kind of know his story. And for whatever reason, he's just got this amazing heart and empathy, and he's always with Kathy. Like he just knows whenever Kathy needs him.
Yep, he
and
does.
how much do you get out of that? In terms
It's immeasurable. When I had the breakdown, he was with me 24 hours a day. He only would leave and eat and come right back. And he just right next to me in the bed. So, yeah, everyone needs a cat.
or a dog, or
a dog.
But it's holistic support, right? I think the whole thing is it's people, it's doctors, it's being with other Parkinson's patients, it's the dance class, it's having a cat or a dog that's with you. I mean, it's a whole variety of things that.
Yeah, I'll add some science to that. I actually read an article about 2 weeks ago that measured limbic, the reward system of the brain activity, dopaminergic activity, and oxytocin in dogs and their owners. Did you know that when you make eye contact with your dogs, because dogs are one of the only animals that willfully make eye contact and not want to kill you, right? They will seek out your eye contact. And when they do, you are not making it up. Your brain produces an extreme dose of oxytocin, dopamine, and the limbic reward happy system lights up in the dog and in you. Isn't that fun?
Yeah,
That's
well,
awesome.
Science.
Yes.
That's cool.
And then they'll eat you. If they're a doodle, because they're lunatics. Yes, ma'am. Yeah, my sock.
I had a question because I suggest support groups and Rocksteady Boxing and all the resources out there, and it's not an insignificant proportion of people who tell me they're afraid to go. They're afraid that they'll see people who are what they may look like down the line, and they don't want to think about that. So sometimes I struggle to. I really want them to get some support out there, and I don't know, how to find a group that would maybe be more at their level or
Yeah,
their
how do you guys
stage
overcome that?
process.
That's an awesome question
Yeah.
because I have had moments like that where you look around the room and everybody's in a big circle and you think, oh, I'm going to be like him, or am I going to be like her, or how come she doesn't look like she has Parkinson's? And I would say to that person, you don't know what's going on behind the scenes. You don't know if they're taking their medication. You don't know if they're seeing a movement disorder specialist. I'll give you one example that fits that perfectly. This woman in my dance class that's a little bit older than me, but definitely is a little more involved. And she said to me one day, "What medicine do you take?" So, no, she said, "Do you take Rytari?" I said, "Yes." And I said, "Do you take it?" And she said, "Yes." And she said, "Yes, I take it once a day." And I said, "What?" And I said, "Do you have a movement disorder specialist?" And she said, "No, I have a primary care doctor. He takes care of me." And so she looked more involved, so I could have said, "Oh, well, I'm going to be like her," but there's extenuating circumstances that you don't know about all the other people in the room. So I don't know if that helps, but
Really good point.
Mm-hmm.
I know it's still going to be scary for people, but
yeah,
sometimes say, hey, at least just go try it out and maybe there'll be someone else like you, and know that Parkinson's is different for everyone.
Yeah.
exactly.
Predict your outcome by someone else.
Well, and you can tell the people who are not doing well, you can't tell the people who are doing great. So I always, if I'm at a support group and it's filled with people, I will acknowledge that and make sure that at some point I ask everyone with Parkinson's to raise their hand. Because then the people who are looking at the one person who looks terrible, who you don't know their history, can realize that the guy sitting next to them who looked perfectly fine had Parkinson's the whole time.
Good idea.
Mm-hmm.
I also think trying to get them to exercise first. You know, because then they're involved. If you try to coerce them into a support group, they're going to sit and look at each other, right? But when everybody's moving, the adrenaline's going, the dopamine's coming up, and they tend to be a little more receptive. Not great, but a little more.
Yes, ma'am.
Gotta get them to exercise.
Yeah, you got to get them moving. Mm-hmm.
I'm a physical therapist at Georgetown, and I actually ask my patients what group they're going to, kind of what the makeup is of the group, and then I kind of pair one of my patients with another patient who's already in the group, so they know someone. I've made a lot of connections where it might be that they've never met anyone with Parkinson's before, but they want to try these new groups, and I have a lot of my patients that are willing to kind of be a buddy, to welcome someone into a group. So I think knowing the groups in your area and knowing the populations of the groups in your area will help you direct your patients also.
And they always love a potluck.
But I really like what you said, because I've seen, in my experience with my patients, some of the best support groups come from exercise groups.
Yeah.
They become support groups. And when the starting point is exercise, it kind of sets the tone, and the support comes as part of the action and this exercise, and which is why the dance class that Inova supporting and making it happen for the community is really helpful. And look, now you've been able to meet that person who's taking Rytari once a day, and maybe it's as simple as telling her, please go see a movement doctor.
I did.
Good. All right. And maybe Dr. Falconer will see her, or one of us will see her. And
You'll see all of us in
yes, maybe.
rotating wheel of Northern Virginia.
Yes, she has all of us there, whenever she needs us. And I think that's so important, because not everybody knows how to handle advanced therapeutics. I mean, this sort of management with IR carbidopa levodopa, not this case specifically, but that we do see a lot as referrals into our practice, and we can really help stabilize people with the proper therapeutics, which is what this conference is all about. So it's so important that we remember, we have a lot at our disposal in terms of what we can offer people in 2024, and utilizing that and using the access tools that we learned from the access panel, and figuring out how it is that we get the right drug for each patient in our patient's hand can be an effective way of providing that support. So it does take this whole team. You see everyone here. You see teams of doctors and APPs come together. And hopefully that's inspiring for both of you to know that there are movements like this that help bring people together and teach people how it is that they can kind of create the best treatment regimen and non-pharmacologic treatment regimen to support patients.
And a non-pharmacological, just as another reference point, I'll go back to my dad, and this is still in practice, the Lee Silverman voice treatment. Everybody know about this? So go back to Dr. Sage. My dad was having a hard time communicating in terms of his vocal, and back then it was only about 4 or 5 years out at that point, Silverman. And he went to Crozer-Chester Hospital, had the full therapy, and had those exercises. But that goes to having the confidence in being able to speak, because he was very self-conscious in communication. But again, it goes back to, again, for all of you, if there are those types of additional therapies that help a patient with their quality of life, that was really critical. The Lee Silverman voice treatment was really, really important for my dad. If you're going to be in a support group, you want to feel comfortable being able to talk to people and have that confidence. And so I love the fact when you said non-pharmacological. Look, this is a disease that requires intervention of medicine. There's no way to treat. You have to go that route. But there's all the other therapies that are helpful in so many types of treatments. Physical therapy, I'm glad the physical therapist. I've got a number of friends who are physical therapists, love physical therapists. My wife's got physical therapy going on right now on her knee replacement, so love physical. But all the things with movement, somebody said about movement and everything else. Again, my dad, when he had Parkinson's for the first 8 or 9 years, you really didn't know he had it because he would walk all the time. And again, it progressed, it's degenerative. I mean, he started going down, but the more he moved, he was doing the best he could be when he could move and walked. And once some of that started getting taken away from him because of some of the muscle rigidity and loss of balance and things like that, you started seeing a decline. So I think those interventions are just so important to make sure that where a patient is on that journey, give them other types of treatments and therapies that are going to help with their quality of life.
I will caution against Lee Silverman voice therapy and hearing loss. I had a patient pull up to our clinic. This is a joke. Pull up to our clinic the other day, and we could hear Hank Williams blaring from the parking lot into our clinic because his wife said now he just sings all the time to his favorite Hank Williams at volume 15.
That's another reason they separate our patients from the headache clinic, right?
Exactly. I believe it was hey, good looking, got cooking. I'm sitting in clinic and I'm like, what? Usually you don't blare Hank Williams, but you gotta do. Okay, team, let's keep rolling. We do have some other cases here. How's everybody doing, by the way? Everybody good? Okay, cool. So now, depression and PD, there are general guidelines. You can see a pretty good constellation of medications there, taking on different aspects of treatment. Remember, MAOB inhibitors like rasagiline or selegiline can impact mood as well. And look, good old pramipexole is listed in the first column because if you pretend to be dopamine, they start to feel better. I'll also put a plug in for mirtazapine, Remeron. It is a great medicine to add at bedtime if sleep is also an issue, and it does tend to work wonders on anxiety as well. Okay, let's keep rolling. So now we are continuing on this theme. We thought this theme would be our first 45 minutes, but we've had great conversation. So let's add one extra layer of now we've done fluctuators, we've done some dysregulation symptoms, depression, anxiety. Now let's tackle a patient who is severely hallucinatory and paranoid, that patient who shows up and all of a sudden whatever time slot you had for the patient is only the beginning, right?
True. So a 79-year-old PD patient male patient with PD, with bilateral STN, DVS, and dementia presents to clinic today. He's got severe hallucinations and paranoia that started worsening about a week ago. The patient's wife is absolutely exhausted in clinic and states she hasn't gotten any sleep. Her sister came to stay with them about a week ago to give her some help. However, the patient has been making sexual advances towards a sister-in-law who is now locked and barring her bedroom door nightly. Wife doesn't want him to be admitted for placement. She thinks she can get him into respite by next week. What do you do?
Well, you apologize to the sister-in-law.
Right. Correct.
Okay, I'm going to pass this. Dr. Yaghi,
Yeah,
first.
you know, I'm like at the edge of my seat.
Does this make you
because-
anxious hearing?
Yes, this is incredible. Even the schematic there makes me anxious.
Yeah.
The guy, multiple,
How I
look,
felt.
yeah, that's how it feels.
Yeah. And it kind
It
of
was my brain in clinic.
It is so incredible how perfect that schematic is.
Well,
for
this is a patient where, as the provider, you have to do wellness activities at that moment to realize what you're about to dive into.
Absolutely. You know, I have to say, it surprises me how often psychosis is pushed aside.
Right.
And I like this case because you have to address psychosis, and the conversation about, you know, all the other stuff is important. But because we have such a great treatment strategy for psychosis, I think would mean that we would have to treat it as soon as possible, right? So in this case, I mean, I think it's a kind of straightforward answer. You have to treat the hallucinations and delusions first and foremost, and move from there, and recognize also that this is a stepwise approach. You start with that, and then you can move on to the other things. And we're going to have to do the and strategy, not the or strategy. We're going to do a lot of things at once, and that's where all those arrows are so important. I'm going to call Renia. Say, mobilize resource management. Renia, help me
She has a
communicate
spotlight. It hits the tower.
of an R. And then I may call Dr. Falconer and say, hey, what do you do in these cases? Help me.
Yeah.
Give me some expertise
No,
over
I
here.
say you're the director of the dementia clinic.
Right. You're right, I do. I take care of patients like this all the time. And I might call Clarisse and say, help me. How would you, as a nurse practitioner, knowing all the clinical aspects to things, how would you help? But this is absolutely very difficult. But I would target the psychosis.
Yeah, the tricky part for me here, and I feel like it just depends on sometimes my mood that day or several other factors about whether, you know, do we put these patients in the hospital or do we do the workup ourselves? You know, because we know if we put them in the hospital, they could potentially get worse, right? Just from being in the hospital.
Oh, incredible point.
Right? But here, we also have someone else's safety who is maybe not okay, right? Although the sister-in-law is locked in the door, I mean, really, that's not okay. You know, we've got some safety issues too. So I certainly did call my social worker to say, you know, I want to do what's best by everybody here, but I don't know what to do. So I think it's tricky. But I'm just curious between the two of you. When someone comes in acute psychosis, and there's no recent, potentially, let's say there's no recent fall, so you know you don't really need a head CT. Do you do an acute workup yourself, or do you send them to the hospital?
Well, so what's going to happen, I can tell you, is that you're going to say, this all changed a week ago.
Right.
He needs blood work. He needs his urine checked today.
Right.
You need to take him to the ER. And the wife is going to say,
No.
no. Last time we took him to the ER, it was a nightmare. He sat there for 8 hours. He was running around. They ultimately put him in restraints. Then they gave him medicine, haloperidol, and he was in the hospital for a week. So what I would do is call up my wonderful social worker friend, and again, how can we resource this? But I would call up his primary care and say, you need to go to the primary care immediately. They'll draw the blood, they'll take the urine, and until we figure out what's going on, this is also a red flag that your dementia is progressing to the point where hallucinations and delusions are part of the picture. And they might be worse because of something, but they're still there. And I would immediately put this patient on quetiapine and Nuplazid at the same time.
I think clinically that makes so much sense, Dr. Falconer.
I mean, pimavanserin, sorry, CME committee.
Oh, that's okay. That makes sense. And you know, this is important. And it goes back to what you and Mr. Bovino mentioned about the healthcare system.
Yeah.
And we're not set up for success in an outpatient setting as movement disorders doctors, really to handle this in kind of an acute manner outside an emergency room setting. And this is, a lot of our patients might fall into that category. You know, we've always dreamed of having our own like movement urgent care center that we could really handle this, do like a spot urine analysis and figure out how to treat the UTI with antibiotics if it was an infectious encephalopathy on top of already a case like this. So, but we really don't have the resources to do that. In fact, it's hard to find the resources for a social worker.
Yeah.
That's the truth. It's been 4 years, and we haven't been able to find the resources for a social worker. And so these things are really hard. These things don't just happen in clinics. Right. You have to push for them. You don't have nurses that are there, you can just hire, even with Dr. Falconer will give us his perspective, but in big academic centers where people think they're going to centers of excellences and they are, there's a lot missing. And there's so much missing. It's incredible. There are so many centers that don't have a Renia. And is it Lucy?
No, well, we just lost our social worker.
Oh, so there you go.
So,
and
I wasn't going to say it, but now we did. By the way, if anyone knows a social worker, in fact, they were just texting me that they improved the pay raise for our position, so I'm just putting it out there.
Well, there you go.
She moved to California.
They didn't freeze the position like they did to us, and it's really, really hard to get the care. I don't even have the right team in place to be able to offer all of these services, even though we're a great center, and even though Inova's a great center, there's so much more that we could do. And these are the cases where we need the whole team. And what I feel is, like you said, anxiety. I know the system isn't set up in the right way. Sending this patient to the emergency room is wrong, but it may be the only option, if there's no way to acutely address this. So this is a perfect example of a complicated scenario in which the healthcare system is not set up to handle.
And the patient loses.
And the patient loses, exactly. And so to spin it optimistically, I think if we do more cases like this and understand where the need is, then we can hopefully equip these centers of excellences with the right team to be able to address these scenarios. But you're right, this is tough.
I'll give a plug, though, just to help with social work, too. And for anybody, ask your home institution, because this just reminded me of something that I forgot about. Because the emergency room in many hospitals is overwhelmed because they're crazy, a lot of hospital institutions actually contract with what they call home urgent care services.
Yeah.
It's nurses who go to the house to do the blood work, urinalysis, et cetera. Inova does it, my center does, my system does it, and I completely forget about it every time. But I think most of even MedStar might do it too.
Yeah, that's what I was gonna add, and this is actually something I learned. It's the MedStar house call program.
That's what
Some of our patients were saying, oh, I feel like the care is very fragmented. There's lack of communication. The patient cannot get out of home as frequently as they would. So they really want all the care to be in home and more cohesive and comprehensive. So I ended up referring this patient to MedStar house call program. Luckily, they were eligible for it, but unfortunately, not everyone is eligible for that service, which is for mostly Medicare patients, 65 or older, chronic disease. But if it can be helpful at least to one family, I would prefer them to. So.
That you both just mentioned something that triggered something I wanted to say. You need a good primary care. And the first thing I tell a patient about how do I pick one, I say who picks up the phone and who can see you urgently. Yeah. Because if you have to wait to see your primary care several days and they can't get you in, which is what's happened now in outpatient primary care medicine and in neurology. Yeah. The way we have our visits stacked in terms of volume, it's very hard to be able to address urgent issues. So if you can't access your primary care to do things like this, to get a response on a result on your urine or your infectious workup in a swift manner, then that primary care center may not be the right place for our patients. So really, urgency does happen. It happens at the spur of a moment, and you have to seek help. And so absolutely, I think that home care service is a big pearl.
And don't forget constipation. Final one. If I always ask these patients, when was the last time you pooped? And usually the wife looks at you like you're crazy, and then they think about it, and every now and then they're like, oh, it's been a week. And you're like, that is probably partly why.
Yeah.
Poop. It always goes back to poop and what we do. Yes, ma'am. Yeah, you did. I slipped that in there, yeah. So the question was, I threw in there how I would pharmacologically treat it, I would use both quetiapine and pimavanserin because if the half-life of pimavanserin is very long, it's like an SSRI, it works on serotonin, so you're talking impact on hallucinations after 3 to 6 weeks. That doesn't help in a crisis. So I tend to do both. I plan for the future and now long-term, short-term. Remember, the co-administration contraindication really isn't a contraindication, it's a warning. And it's about QT prolongation.
So will you get an EKG?
So yeah, I make sure they have an EKG, part of that workup with the blood work. But realizing that the extension of QT with quetiapine is about 5 whatever volts, and quetiapine's maybe 4 to 6. So all in all, it doesn't extend it very much. So if they have a normal QT interval, really it says keep an eye on it, but it shouldn't give them trouble.
And grapefruit juice can extend it by 15 or 20.
Say again?
Grapefruit juice.
Yeah, grapefruit juice can extend your QT interval by 20, so it's small. So I was leading up to say if the patient is then better on quetiapine and pimavanserin, I would just keep them on both.
Would you recheck the EKG?
I would recheck an EKG when they follow up with their primary care doc.
Just curious.
With that first workup. So I start both, and usually there's one floating in the system, usually. Thankfully, our system pulls from everywhere, and they've all had some sort of little surgery or yearly checkup. So usually there's an EKG in there. But if there's not, I just tell the family, don't start the pimavanserin, until you've got your EKG, because the immediacy is the quetiapine.
Yep.
So get the quetiapine on as soon as you can start it. Well, it depends. For this psychotic patient, it sounds like it's worse at night because the sister-in-law is locking herself in a room. I'd tell her to give 50 at night and 25 in the morning. Or I'd go higher. I would keep going. I have most of my patients on pimavanserin are also on quetiapine. And usually it's at bedtime, and usually it's only at bedtime, because these patients have the worst issues after 5 p.m. until the next morning. And don't forget, quetiapine as a medicine, under 200 milligrams a day, only works on histamine. Quetiapine only starts to block dopamine once you've hit about 200 milligrams cumulative dose per day and beyond. So if you're below 200, you're really just giving them an antihistamine that's kind of knocking them out. It's sedating them, right? So that's why keeping it lower helps. And if their QT interval's fine, why not use both tools which achieve the same goal?
I always ask myself, being an APP, sometimes we get caught in the weeds of being anxious about using those two together. But I always say, is this going to keep the patient in their home with the caregiver able to take care of them? Then, is the QTC okay? Well, then I can, lower my blood pressure and move on.
Yep. Dr. Yaghi, any other thoughts on that wonderful combo?
No, I agree. I think that's a nice therapeutic strategy. Absolutely, it's not uncommon for us to utilize quetiapine in conjunction with Nuplazid, given that it takes time for Nuplazid to take effect. You could always consider, the removal of quetiapine in the future, but dual therapy is something that we utilize for a severe psychosis like this and delusions. Some you can remove the quetiapine later. Some you'll keep them on lower doses at night, like you said. But those really are two agents, right? And pimavanserin. In fact, if you can't see an immediate effect like you do with quetiapine. And as you said, the histaminergic modulation is really what we're looking for. But then you have to worry about sedation, orthostatic hypotension in those patients that already have widespread, diffuse pathology of synucleinopathies.
Yes, ma'am.
Why would you not decrease the dopamine? So you're going to start quetiapine immediately, but you're not going to get pimavanserin immediately.
That's true.
Right?
Good point. Yes, that's another strategy.
That's true. And it depends on what medicines they're on. If, again, back to the GoCover example, if you're on extended release amantadine.
DRER.
And you're taking 2 of them at bedtime, yeah, great time to back off. Yeah, especially if you're on a dopamine agonist, you got to get that down quick because that's like gasoline on the fire. Levodopa, though, is a little different. I can't think of the last time I reduced a levodopa dose in the setting of psychosis, only because then you're going to have a psychotic patient who can't move and is tremoring, and then you're dealing with. Well, they can't get to the sister-in-law. That's valid. It's valid.
Right.
This one's got TBS, so
Yeah,
Yeah, he's not amazing.
yeah, that's true. I agree. Yeah, thank you. Any other thoughts on this? Hey, would anybody treat it differently? I'm just curious. Because we see these, and this is the ones that make me nervous, too.
And Mr. and Mrs. Bovino, any final thoughts? Anything that you had wanted to communicate, not about this case, because we're nearing the end of this podium presentation.
Oops, sorry.
Anything you've been wanting to say, because I know Mr. and Mrs. Bovino prepared for this, and they were so excited to be able to communicate to all of you their own experiences.
Well, I'll share, because Kathy's checking her notes. I know she had other things she wanted to share, that I so admire Kathy, because she takes an approach to this in a very optimistic, positive, realistic way. And all three of those words are important, optimistic, positive, but realistic as well. And she's always reading, always looking, always interested on how she can improve her life and what are some resources that are available. Then she'll dive into those things, with, again, the Parkinson's dance class, for example, just a tremendous addition to her life. I think, in terms of that, that positive attitude is really important. When you're battling depression and anxiety and some other things, it makes it difficult, right? So I think every day Kathy wakes up, and I'm so proud of her, because she does, again, realistically, positively, optimistically kind of looks at things. But she's surrounded with a lot of positivity, again, with her support, whether that be through the Parkinson's dance group, whether that be through her friends, whether it be that through her home environment, yes, including our cat Henry, whether that be with Dr. Yaghi and his team, whether it be, we have a great primary care physician, who's always involved and always is asking those right questions. I think all of those, again, goes back to that network of support is just, really, really critical. And then having, and again, you've spoken about this before, Kathy is a great admirer of Michael J. Fox. I know he gets a lot of people admire him, but what she's always shared with me is that what strikes her about him is that he speaks real. He doesn't sugarcoat things. He talks about the reality. He talks about his ups and downs and his struggles with alcoholism and things that he had to get through when he had his down moments, but always, always, always kind of like Kathy, looking forward to the progress and what are we trying to do here. And I think it's important that you have people look up to like that, like a Michael J. Fox and others that have, that have gone through that journey. And I know you're inspired by him and others as well. But I'm so proud of everything that you do, because you are really inspiring.
Thank you. Thank you. I'm so lucky.
Do you have any final?
What did you have on your notes? And I was giving you time to look through your notes.
Oh, thank you. I think having a sense of humor has really helped me a lot, even though I'm starting to cry. Because it sucks. You don't know what your life is going to be like. You don't know what symptoms you'll end up with. You don't know. And it sucks. But I think it's a two-sided thing. I think you need to have a sense of humor, critical, but you have to get mad sometimes and just, let yourself be angry at it. And, then it's more of a balance, because for 6 years, I didn't have a balance. I just, was cheery and joked around about it, and it was always funny, and I just pushed it aside. And once I looked it in the face and dealt with it and said, I have Parkinson's, it made a big difference. So I think being a realist is also part of that. Being a realist about having that disease, nobody wants it, but you have it. I have the best possible support team, and I think if you can encourage anyone, if they don't have that, do what you can to bring these people into your life, like Mike said, friends, other people with Parkinson's, great doctors that also have a great sense of humor, and you know, who are kind and caring and spend time with you, and to have that one person, this guy, who you can always count on, and who accepts you the way you are, and you know that no matter how bad it gets, they'll still be there with you, and you know, being on the journey, and it is a journey. So whatever capacity you work with people with Parkinson's, thank you on their behalf, because whatever it is you do, even if you think it's very small, that your role is very small, it's not. Because everybody makes a big, big difference. And it can't just be one person that you count on. It needs to be a team. So thank you. And thank all of you, too.
Yeah. And thanks for listening. Thank you to the panel for your thoughts, opinions, and jokes. And that brings us to a close. So thank you, everybody.
Thank you.
Thank
Thank
you.
you.